We do this every Tuesday at 12:30. So glad you could join us today. We even got our illustrious Dr. Schuler on here today to do some presentation regarding telehealth. So I'm really happy to have him. And our topic today is going to be telehealth. We're going to talk about what happened, what it was like in telehealth before the pandemic, what it was like during the pandemic, and what it is likely to be like in the future. One of the things I want to let everybody know is that as we discuss this topic today, we're still in discussions with TennCare and with managed care organizations about what the rules surrounding telehealth are going to be. And so those are not fully solidified yet, but what we're really going to focus on today with our panelists is best practices with respect to telehealth and things that as we move into the future, if we're going to have the ability to do telehealth as clinicians, how should we be doing it? And so we've got a great panel. We've got today a board certified behavior analyst, licensed behavior analyst, Carrie Donarajan with us. We also have with us David Taylor, our director of nursing for DIDD. We have Sarah Muncher. And Sarah, you're an occupational therapist. And so she is going to talk to us about the rules surrounding therapies. And Dr. Schuler is here to talk about telehealth in medicine, telemedicine, essentially. And so we've got a great panel. I'm going to let them introduce themselves here in just a moment. But that's our topic for today. Coming up on CCN, next week, we have one of my great friends, Tim Barksdale. He works with Marikey. He's one of their clinical directors. And so he is going to be here to talk to us about some of the work he has done through Marikey and some of the things he has planned for the future. He's also a NAD board member. So this is our fourth Tuesday NAD collaboration. So we're so happy that we're going to be able to have Tim here next week. On May 2nd, we have the National Association. She is the CIT trainer essentially across the state. And so we're so happy that she's going to be here to present to us. We've had many presentations in various forums by her before, and she's really a great presenter. On May 9th, we've got a case presentation. Do we know anything about the case presentation, Babs, or are we still collecting information about that?
We're still collecting information at this point.
Okay, so we'll find out more about that and tell you more about that next in the coming weeks. May 16th, we got 10 Start Mental Health with Michelle Bagby. So glad that she's going to be on to present about this very important program that we have within the state. May 23rd, we've got our NAD collaboration again with Dr. Brandy Kelly. So she is going to be our fourth Tuesday feature during May. And then, we got us a little bit, this must be May 30th rather than May 20th. I tell you what, I'm smart. I figured that out. So we're going to have Tennessee Association of Mental Health Organizations and Volunteer Behavioral Health here talking about 988, which is a new important service as well that's out there. So we've got a great lineup coming up, and we're full all the way through the end of May. So that is really great. And so today, I've already talked about our panelists a little bit, but I hope you will welcome them. And as each of you come on, I hope you'll introduce yourself just a little bit, tell a little bit about your history, and don't forget to include that fun fact about yourself as you introduce. Okay, so I'm going to go ahead and get us started if that's okay. Carrie, you're going to be first up. And so take it away.
Okay, wonderful. So my name is Carrie Donarajan. I work with the 10 Start team, but I'm also a board certified behavior analyst and have worked as such for many years and was working as a clinician when the pandemic struck. So this is definitely something that I think is a really important topic for us. And as we talk about it, well, I'll get into my presentation in a minute. I got to give you my interesting fact. So I've been with the state for 18 months now. And like I said, I've been doing behavior analysis for a long time. And my interesting fact is that I've got a really big one I can pull from for a while because we took an India trip. And so I have a bunch of little now interesting things about me to tell. But on our trip, we went to a church in South India in the city of Chennai. And there are only 3 churches that were built over top of the tomb of one of the disciples, or I guess apostles. I guess I should have checked that wording. But anyway, we'll say one of the disciples. And we went to the church of St. Thomas. And so Thomas, the disciple, had been buried under that church and Rome. There's one in Rome. I think there's one in Spain, and then this one in India. And so it was really interesting. The body had been moved, but they do have like a relic, which was cool. It was really cool to see. And yeah, so that's my interesting fact about myself.
That Chennai is down on the southeastern coast, right?
Yes.
Like,
Yes.
Kind of like if you were going to Sri Lanka, you'd probably leave from Chennai.
Yes. And it's a very Christian area of India. Percentage wise, there's not mostly Christians, but it's the more percent of Christians in that area versus in the north where it's much more Muslim and Hindu. So
it's very highly populated too, though, right? I mean, that's a big city.
Yes. The cities are much huger there than we have here.
Hyderabad, Ahmedabad, Pune.
Yes, you're talking millions. They measure their population in the millions, not the hundreds of thousands.
Right. Well, without further ado, go ahead and tell us about what you found about telehealth, Carrie.
All right, I'm going to share my screen. Someone in the comments said they were having trouble hearing. My microphone is turned all the way up, so please let me know if you continue to have trouble hearing. All right. Hopefully everybody can see that now. All right, so today I'm going to talk a little bit about ABA and telehealth, and to kind of go over my agenda, I want to talk about a little bit of an overview of telehealth, the impact of the pandemic, Appendix K, which affects our services when it comes to behavior support services. It affects a lot of services, but I'm going to touch on the behavior part, and I'm going to talk about best practice and have time for questions. There's 2 articles. I know it's really small. Babs is going to send out the resources, but I read one of the articles was comparing telehealth related ethics and guidelines and a checklist for ethical decision making in the midst of COVID. That actually compares the BCBA ethics. It pulls from APA and one other field, which I don't remember off the top of my head. But anyway, it pulled together like not just our practice, but kind of to look across the board at what people are doing, because this is sort of new ground a little bit. And of course, I pulled from the ethics code for behavior analysts. So what is ABA telehealth? ABA, of course, when we say is applied behavior analysis, it's what us behavior analysts do. And so what does it mean to have ABA telehealth? So I pulled some things from the web to kind of give a picture of that. Telehealth is a term used for health-related services that take place through an electronic device. Simple enough, but it can get complicated. One source said two-way video conferencing. Another source said delivering healthcare services via information and communication technologies. Pretty broad. One source said it can take place on any device that has a built-in speaker and webcam. So a little bit more operationally defined there, like a smartphone, tablet, iPad, or laptop. Telehealth can be as simple as using a phone, tablet, or computer to connect face-to-face with your healthcare provider using a HIPAA-compliant voice or video platform. Before beginning the use of telehealth, a patient supervising BCBA must deem telehealth as clinically appropriate for the patient's specific needs. We're going to talk a little bit more about that. And the patient or their family must give approval. Telehealth is not suitable in all cases. And I think that's something we'll see more. One of the articles I found that talked about telehealth said there are 3 technologies that can be used for telehealth: web cameras, swivel, and telepresence robots. And so that made me think of the Borg collective. But I mean, there really are robots, like a tablet on a robot, that could move around. So telehealth isn't just necessarily as simple as an iPad. It can be more, it can be like pretty basic, but I think there's a lot we need to consider when we think about doing good telehealth services. So let's take a trip back to the year 2020. All right, we remember this year very well. So before 2020, telehealth was a thing. I mean, there was telehealth going on. in the world of behavior analysis, but it was fairly limited. And it was mostly used, to provide supports to people who were like, in faraway countries or didn't have resources, maybe rural areas. But because of the pandemic, we had mandated social distancing, right? We all stayed home. We had these executive, or orders, I guess, that were stay-at-home orders. And the Board of Behavior Analysis Services, BACB, put out a statement about following your local directives and things like that, and taking care to safely provide services. So there was a quick turnaround, and the rates of telehealth began increasing. And a lot of that was because insurance started paying for telehealth. So in the meanwhile, while we couldn't go out, there were people who couldn't have gaps in their services. They needed those services to continue for their safety and so that the families knew what to do and so that gains weren't lost. It was really important. So that did start happening. And I think it was a really good thing that the pandemic did that, in fact. All right, so Appendix K.
I just wanted to interrupt just for a second and remind everybody, if they have questions as you're speaking, what I'd like for you to do today, instead of coming on vocally and asking them, is to go ahead and put them in the chat box, and then we'll handle all the questions toward the end. So that way we can make sure we get through all the presentations. But if as they have questions, go ahead and enter them in the chat box, and then we'll go back up and handle them toward the end.
Awesome. Yeah, and I can't see the chat, so do stop me if I need to stop. But
and I do want to encourage people, please do ask questions if you have any.
And if I miss anything or you disagree, put that in the chat too, because just kind of doing our best to talk about the best practice here. But okay, so in Appendix K, it stated that only during the COVID-19 emergency, behavior services may be provided by telehealth. Generally, this means the person and the provider are connected via an interactive audio and video telecommunications system. And any components requiring directive evaluation or interactive hands-on care are excluded, because basically Appendix K, the spirit of the law was to be that we are giving the best services possible, that we aren't skipping and not doing things that need to be done in person because now we can do it by telehealth, but instead we were prioritizing safety. And so doing the things we can do by telehealth. So except as provided during the COVID-19, Appendix K also lists the things that need to be done in person. And so if the health emergency ends, it may be that we are returning to a pre-COVID situation after the health emergency. That's kind of something that Bruce noted, was like hinting at. We don't really know exactly what it's going to look like after, but we do know that right now some telehealth is allowed. Telehealth gone wrong. When you go to do telehealth, if you don't have all your ducks in a row, technology can let you down. So the scheduled session, we can't do it because there's no internet. My computer's not working. It's restarting. So then the person on the other end is just waiting, those sorts of things. We need to be really careful about that. It can be that no one on the other end of the computer or the telehealth session is consistently delivering the contingencies or following through on your plan. You're not in person. You have a small view into that world, and you're trying to teach and you're trying to guide and implement, but if no one's on the other end delivering, that can be a real problem. Background noise, pets, siblings, these can really distract your telehealth sessions. I had a kid I was doing telehealth with, and we were supposed to be working on verbal skills, and I had a nice computer presentation, but the television was always blaring in the background. So it was really hard for her to attend to me with the television on, and I couldn't reach through the screen and turn the television off. So unless you have an adult there that you can talk to really assist, that goes back to the other barrier, it's going to be hard to do those things. But thankfully, we did have a person that we could be like, hey, can you turn the TV off? But it doesn't always work perfectly. I did want to note, like in Tennessee, there was a recent choking death where behavior services had been put in place, but the entire assessment was done over the phone, not face-to-face video conferencing, but over the phone. And further follow-up was done over the phone. So again, that puts us in a really delicate position when you haven't really followed best practice. If something goes wrong like that, I mean, it's possible you could have prevented something from happening like that. With telehealth going right, with the proper planning, telehealth can have key benefits. We're more flexible. We can be in different environments. We can go in the community. We can go in the home, and we don't have to travel to those locations. So you can fit more sessions in, provide more services. You are not impacting the environment when you're observing. If mom puts you in a webcam and you can even turn it in some technologies, you can just sit up there on that webcam and watch what really happens when no one's there. And sometimes for parents, that's so helpful because they just want someone to believe what they tell them. Like, when you're not here, it goes like this. Well, now we can do that. And then you can do less cost and more in vivo training with treatment plans that can happen because you can be there more easily. There are considerations, though, because we want best practice. The therapist needs to be suitable to telehealth. They need to have some training on how to do good telehealth services. This isn't just flip on your computer, turn on Zoom, and we're good to go. You have to prepare those sessions ahead of time. You have to be ready with the technology. ABA services in person and telehealth are considered separate areas of expertise, and that was noted in the article that I was referencing. So it's our obligation to become trained in that format of doing ABA. And also on like, how well do you use technology? If you're fumbling with the volume in the microphone and in all of it during the whole session, the person that you're trying to work with is going to get distracted, turned off. They're going to be done with your session. And so you need to be ready with your technology ahead of time. Also a note here, your technology has to be HIPAA compliant. I know we had said that before, but like that's really important because you're dealing with people's private health information when you're online like that.
And Carrie, that had been a flexibility before the pandemic or during the pandemic that we didn't necessarily have to have a HIPAA compliant system, but now you do.
Yeah, and I think there's lots of HIPAA compliant systems out there. Some of the systems we started using, like Zoom, started out not compliant, but they realized pretty quick they had to be compliant to keep up. So it might be a paid part of the service, or you might have to get a special service or whatever, but you need to make sure that what you're using is HIPAA compliant.
Apparently, some people are having a hard time hearing me, but you're doing a good job of translating the questions. So I'm glad you can.
Okay, I can hear you. So I hope everyone can hear me. Okay, another thing we have to do when we start a telehealth session. So this is, again, thinking about best practice, assess for safety and consider both your environment and their environment. Are there distractions, noise, other people? Does the room meet recommended standards for privacy and confidentiality where you are? So if I'm in a coffee shop and your kid is on the screen because I'm doing a session, that's not private. That's not confidential. And so you got to be really careful where you're doing your work and in the room that you're in. Is clients' personal information visible to others on the screen? And are you, like I said, protecting the client's privacy? And then on their end, they need to be aware too that, they need to protect privacy. They need to have their HIPAA compliance in place for if they choose to. Obviously, they can choose not to, but some issues to consider so you don't get in trouble. I'm rushing through this end because my time is over. Client appropriateness. Are they interested in telehealth? Are they appropriate for telehealth? Are there cultural issues? If they don't want telehealth as a BCBA, I can't force them. I need to work with them to make it work for them, especially now. Speaking not about the health emergency, but like just as a BCBA, we're going out, we're doing things now, not like at the beginning of the pandemic. So you need to really work with those clients to give them what they need. The client's technology should be appropriate. Again, you can't do the service if their side isn't working, lighting, sound, all of that. Finally, I want to mention this, safety. So because you're not in the room with someone, you can't keep them safe in the way that you would if you were. So you need to look at physical safety, their safety, safety of others. And then when it comes to ABA, if they have severe self-injurious behavior, you may not be able to help with that on telehealth because you aren't there to keep them safe. So that, again, would be unethical. You can't just sit there and watch them through the screen hurt themselves unless you have a plan in place for someone on that end to be keeping them safe and to really be communicating back and forth what's going on and giving a way to help them with the issues they came to you with. So just in a summary of that part of the ethical best practices when it comes to telehealth, telehealth isn't just, oh, we can just do our services at home and that's great. We can all work from home now. Telehealth is a way to facilitate services, to help things move more smoothly, to have more access, but sometimes it's not appropriate. And as a behavior analyst, following our ethics code, we have to be able to say that sometimes and say, this is not an appropriate case for telehealth and the safety of this person. Either they need to find someone else who can be in person, or I need to go out and be in person to do this right. So race through that, but any questions, they can go. I guess Bruce said we're going to wait till the end. So
let's go ahead and have them put it in the
remember
chat.
Spock. Yeah. And I'm going to stop sharing. Thank you, guys.
I don't know if people can hear me any better now or not, but if you can, okay, it's better. I think I got a new camera and I think it was covering up my mic, so that may have been the problem. In any case, okay, so thank you so much, Carrie. That was great. Good overview of telehealth for behavior analysts. I think now we're going to move to our director of nursing, David Taylor, who's put together a presentation as well for other professions, and he and Sarah are going to tag team here on therapeutic services. So, David, take it away.
Good afternoon, everybody. Wow, that's a hard act to follow. Carrie, that was excellent. Thank you so much. You covered so much stuff that is so pertinent, and that was just absolutely wonderful. Babs, can you, I guess real quick though, don't have a lot of interesting things going on with me right now. Y'all heard several of mine in the previous CCNs, but here is one of the things that's new for me is, I hope y'all can see this, is my new cat.
Oh my goodness.
Named Maddie.
Everybody out there, they're all muted, but everybody is collectively saying, "Oh," right now.
We had an older cat that unexpectedly died last month, and so we have found a friend for our other cat, and they're not getting along real well yet, but we hope they will soon. But anyway, so I guess we can get back to the presentation. Babs, can you throw that up again? Or do you need me to? Thank you. And then just skip to the first slide there. All right, this is just basic definition of what it's telemedicine. It's practice of medicine using electronic communications, information technology, and other means. It's not only, it is not an audio only telephone conversation, email, instant messaging, conversation, or fax. So just bear in mind, you got to meet the guidelines of what is a telehealth interaction. Next slide. And Carrie hit on a lot of these best practices for telehealth. Not every situation is appropriate for telehealth, and we need to be mindful of that and apply that as appropriate. And the next slide. And regarding the HIPAA compliant platforms to use for telehealth, they have been opened up. There's a lot of flexibilities for that during the public health emergency, and that will end on May 11th. But these flexibilities will not extend through that 6-month wind down period. The Office of Civil Rights is going to provide a 90-day window. It's providing a 90-day calendar day transition period for covered healthcare providers to come into compliance with HIPAA rules with respect to the provision of telehealth services. So bear in mind, if you don't have a HIPAA compliant platform for your telehealth services, you will need one within 90 days of the end of the public health emergency on May 11th. And the next slide.
So doing the quick math, that's August 11th or somewhere in that vicinity.
So right now, they're allowing non-public facing remote communication products such as Apple FaceTime, Facebook Messenger, video chats, Google Hangout, WhatsApp, video chat, Zoom, Skype, and other products. But these will not all be compliant at the end of that date. So just search out what you need for that platform. And the next. And now I'll slide over to Dr. Schuler. I believe he's going to tell us about prescribing medications and such through telehealth.
Well, that was quick. I guess I got to get ready. Everybody hear me okay? No?
It's a little
I can hear
soft.
you. Yes, I can hear you.
Well, Babs is shaking her head.
That's better.
You say no, can't hear. Okay.
All right.
You're a little bit, I mean, you could be louder.
Well, I am pretty loud already. Let me just go over to audio settings and see where my microphone is at. Hold on. Is that any better?
I'm gonna let Babs be the judge of that.
You just sound far away from your mic.
I am not. Let me switch over to a different mic. How's that?
Much
Better.
better.
That's
Much
that's
better.
very rich, very rich.
Okay. Well, let me just follow up on one thing that David said. David was talking about the 90-day window to get HIPAA compliant with your platforms. And Dr. Davis mentioned August 11th. Just a reminder for our department employees, you have to be HIPAA compliant now. So our department has HIPAA compliant platforms such as Teams. So there is no grace period for us. My understanding is that if somebody else starts a telehealth on their end, then you could join that. But if we are starting one, it has to be HIPAA compliant. We're talking about best practices, and best practice in psychiatry and in medicine is seeing a person, touching a person, being there with their loved ones, trying to learn more about them. That is best practice. Telehealth is an acceptable practice. It's not best practice. So then you have to look at best practice of the acceptable practice of telehealth. So I just kind of wanted to make that clear. I spent a long time in psychiatry training with analysts and that kind of stuff back when we used to do that stuff. And you had to sit in a certain way. You made sure the clock was behind the patient. So if you got bored, you wouldn't look like you're looking at your watch. You can just look kind of through them at the clock. So I mean, there were these little techniques that we learned, ways how to end an interview, starting to shuffle and move. So these nonverbal cues that don't come across well on telehealth. I can tell you, but telehealth can be very useful. And certainly if the choice is not seeing anyone at all, versus telehealth, then that becomes the best practice. And that was an issue during COVID. People could not see patients. They had to get their medicines refilled. They had to be seen. So at that time, it was the only practice you could have. And I suspect in the future, it's going to stay. Obviously, patients have a big role in this. Many of them want to be seen by telehealth for a lot of reasons, including convenience. Think about the patients that are agoraphobic. This is great for them. They don't have to go to the office anymore. There's rural issues where people just don't have access in certain parts of the state. I can tell you my own telehealth experience, and it's interesting only for one reason. I had a sore throat. I looked at my throat. Obviously, it was strep throat. I knew what it was, but can't write my own prescriptions. So for you state employees, we have a service called Teledoc. So you sign up for Teledoc. It was great. You put all your information in, and I had a doctor see me within 10 minutes of starting the process. The audio visual failed, but he basically said he couldn't see my throat anyway. But the interesting part of this was the doctor's name. His name was Dr. Pepper. So I got to see Dr. Pepper via telehealth. But it was a good experience for me. They prescribed me antibiotic. I got better. If I hadn't got better, then I would have had to go somewhere else to see why that didn't work. Could have been something else that could have been, a nodule or something that was growing that needed an ENT to see. So you do have to follow up in telehealth with a real doctor, seeing them in person if things don't go well. I can say a little bit about my own clinic and telehealth. One of the things I do is the regional psychiatric review team. So I've been doing this for 15 years. For the majority until COVID, we saw clients in person. Sometimes we'd go to their house. Most of the time, they would come to the regional office. They would come with some members of their team, and we would see somebody in person, do a review for about an hour and a half. And when COVID happened, we couldn't do that anymore. So we switched over to a telehealth version. And the pros, the benefits of doing it that way, first of all, there's less no-shows. When you get a team together of 4 or 5 people, all meeting in the regional office or at someone's home at the same time, and someone doesn't show, then you've wasted a lot of professionals' time. Also, if they don't show, for my case, the psychologist that did the review spent 20 hours doing a review, and that time is wasted. So you do get less no-shows. That's good for the psychiatrist and the team. Additionally, some people just don't travel well. We would have folks that had significant behavior problems, and their team was scared for good reasons to bring them to the regional office. So now those folks can be seen on telehealth. Additionally, people that have severe medical problems in addition to their psychiatric problems, they can be seen. There's another benefit is that more people can participate. It is easier for other caregivers and members of the circle of support to join in this way. But some of the cons that I found, and this applies to not just this clinic, but kind of all things, at least in my psychiatric experience. One, you can't read the room. And reading the room is very important when you're seeing a patient and there's others in there, because the patient may be telling you one thing and it's a delusion, and you have someone else in the background shaking their head. Well, that tells you something. Or sometimes other people are shaking their head, and that's just because they're not person-centered. And so you're looking at the staff member who's shaking their head at something the patient said really reasonable. You get a little idea of their caregiver's attitude. Another con, I said that more people can come. Well, that's a pro, but it's also very difficult. I've done RPRTs where there's 20 people that show up, and they're all, most of them aren't on camera, and there's just these little bubbles and phone numbers that are saying things to me, and I don't know who they are. I don't know how to, how much credibility they have. So at times it becomes almost like a circus to try to manage when you have too many people. But I've never set a limit. Sometimes I wish that I had, but I don't know how to set a limit. And, I don't want to be the person ruling in who's there or not. The only person that can rule in who's there or not to me is the patient. So, if the other folks want to come, I'll just have to kind of work my way through that. It's hard for me to get an evaluation of a person's movement. That's one of the things I look at on mental status exam. I'm not only trying to see if they're tapping their toes because they're nervous, I'm looking for tardive dyskinesia, side effects from medications. Also important to me is someone's affect, kind of the way they look, and that's difficult to pull out by camera. Um, when I used to go to folks' houses, I would learn a lot by just looking at the house. I mean, if the house has broken out windows and plywood in its place and a big lock on the refrigerator, I'm now learning something about what the staff feel that person needs. They may not need it, but I'm learning something about it. So you can learn a lot about the environment. That's something that one of the reasons our START team, our START facilitators, they go out and see people in, where they live. And we learn so much more that way. And I guess the last thing I worry about is allowing for privacy. It's sometimes hard, for the person that I'm seeing to know who else is on the phone call. It's hard for me to know who else is on the phone call. And sometimes when people show up as, just a little avatar, you don't know who else is in the room with them. So, from the patient's perspective, it's a difficult arena to enter, to talk about private things when you can't assure your privacy. So I usually start off by addressing that, I know it's difficult to talk in this sort of form. How comfortable are you with it? Tell them that they could stop it, anytime, if they feel uncomfortable, and let me know. I mean, I do that in all my evaluations, but sometimes it's important to re-emphasize those things doing telehealth. Um, as far as the telehealth rules that are coming out, I mean, I can't speak for what TennCare is going to adopt or what they're going to approve in telehealth. I do know that the DEA has changed some rules already. So Tennessee's going to have to follow those. Babs, can I just get you to put up that one slide that I sent you? Not that DEA slide. I think it's another one. It's the one with the squares and the circles.
I'm going to stop and reshare.
Basically, when COVID happened, one thing I don't have a slide on is that they allowed telehealth to cross state lines. So practices that had telehealth already were able to expand other places, and that was very beneficial. We had that benefit with Station MD. The doctors didn't have to worry, they're based in New Jersey. They didn't have to worry about providing services in Nevada or Tennessee. That rule is changing to where they can't provide telehealth services in another state unless that other state allows, which a lot of states have these dual telehealth license. So if you're, or actually dual licenses, it's getting toward a national licensing system where states that are in the program, and Tennessee is one of them, will allow reciprocity for other states. So that's one issue with telehealth that we have to look at the laws a little bit more closely when we're providing it. But the slide that just came up is just the one about scheduled medications. Scheduled medications are medications that are opiates and benzodiazepines and certain types of seizure medications, gabapentin being one of them. Schedule 2, well, Schedule 1 are illegal. So Schedule 1 is heroin, Rohypnol. Those are illegal medications. Or I guess it's better for me to say they're not legal anywhere, just instead of saying illegal. But Schedule 2 are opiates. OxyContin would be the one everybody would kind of know of. Fentanyl is one. I mean, we hear a lot of negative things about fentanyl, and all of those are true, but it also does have its purpose. And fentanyl is a Schedule 2 medicine. And then you get Schedule 3 and 4 is things like Xanax or gabapentin. So in the past, a telehealth doctor could see you, well, in the recent past, a telehealth doctor could see you and prescribe a Schedule 2. So they could prescribe an opiate, OxyContin, without actually seeing you. They've changed those rules now. And for those of y'all using Station MD, Station MD has probably contacted you already about the changes, but at this point, you cannot, a telehealth doctor cannot prescribe a Schedule 2 medicine like OxyContin unless you've been seen by another physician in person who referred them to you. I know that sounds kind of tricky, but let's say you had a chronic pain issue and you went to your family practice doctor, and your family practice doctor saw you in person and said, I think you need an expert to treat you. And we know this telehealth expert that can do a good job. That telehealth expert can now prescribe an opiate to you because you've been seen by a doctor in person.
Dr. Schiller, quick question there. So let's say the situation was that the prescribing or the doctor who had seen the person in person had written a prescription for pain medication to include, the question I guess would be, did they, because they can't include refills with that, uh, or could they? And could the Station MD doctor fulfill that prescription that had already been implemented for the person?
It depends on what state. Every state has different rules. I don't prescribe Schedule 2s myself, so I'm not completely familiar with the rules. But yes, and I mean, in that case, it still meets the rule. They've been seen, and Station MD could continue. Now, if it's a Schedule 3 or 4 medication, a telehealth doctor can write it for 30 days, and then at that point, they have to be seen in person. I'll tell you, the Station MD has chosen not to go that route. Their lawyers have told them that no, you need to have a referral for everybody. So these rules can be tightened up by the individual practitioner. Some practitioners just may never do it. I know when you go into my doctor's office, there's a big sign that says they won't prescribe any controlled medications to anyone. I don't think that sign's just for me. So a lot of doctors, unfortunately, are going that route. And I say unfortunately because there's a lot of need for appropriate pain management. I just wanted to mention those things. There will be changes that we already know about from federal law on the prescription of opiates. But also remember that there are some medicines that you think are not scheduled that are, like gabapentin, also called Neurontin. And that medicine has a really significant withdrawal. So you don't want people to go without medicine. I guess, did I cover what I'm supposed to cover?
Yeah, I think so.
Okay, I mean, I didn't know. I mean, I'm just talking.
Well, I think you gave us a lot of good information there, very helpful. So, with that, I think we need to move on to Sarah Muncher, who is an occupational therapist. And so, Sarah, why don't you take it away and tell us a little bit about therapeutic services? David talked a little bit about this, but I think you're going to add to what he said.
Yes, good afternoon. I am the Therapeutic Services Coordinator for Middle Tennessee Regional Office. And back in 2019, our team started looking at different discipline position papers on telehealth services due to just the widespread need of therapeutic services for people. And we learned that some clinicians were already using methods of telehealth, such as the store and go, where they were reviewing medical records, weights, blood values, and then providing services. And then 2020 hit, and we were very thankful that we had been looking at those position papers because we knew that the professional associations recognized the possibility of the benefits of telehealth. So since the beginning of 2020 until now, we've seen a lot of benefits of telehealth, but we also have seen some challenges. The benefits, people, their needs are being recognized, training has occurred, we're able to help reach people's goals, and also to try to ensure they're healthy and safe. But with some of the challenges that we've seen, if we have to introduce new equipment to people, it's been a little bit of a challenge. We had one situation where we were trying to help a person with transfers, and the person needed their staff to use a gait belt for transfers, and the staff had never used a gait belt, didn't even know what one was, so we had to do a lot of training and some problem solving. We had another scenario where someone received a new wheelchair, and it's almost impossible, or at least very difficult, to do wheelchair positioning through telehealth. So sometimes there are definitely needs to be a on-site visit, and when an on-site visit is needed, that's what needs to occur, and telehealth cannot take the place of it. So as our public health emergency ends, we need to review the rules and regulations regarding telehealth services. And each funding source has their own rules, and most of the therapeutic services that people in our services receive are through Medicaid. So the information that I'd like to present is based on a Medicaid perspective. So due to the difference with all the regulation and the statutory language, it's very difficult to interpret the healthcare rules. So we have consulted with our DID legal department, our professional associations, and our licensure board to help make some interpretations based on the information that we have available today, because we know things are very fluid and things change. But in April 2022, there was a health or telehealth bill passed. And in that bill, it states that an in-person encounter within 16 months of an interactive telehealth visit will be needed starting at the end of the public health emergency. So what that means is that with the new telehealth law that was passed in April 2020, that each discipline's licensure board will have to meet and draft rules on how to implement the new telehealth law. And that takes a little while. At this point, there are no laws with the licensure board. So that's going to be a process that everybody will need to be monitoring. Um, so starting May 11th, when the public health emergency ends, the in-person encounter within the 16-month of the interactive telehealth session rule that will go into effect. And also with that change, the supervision of therapy assistants will have to be in person starting on May 11th. So it's going to be really important for each clinician to stay active with their professional associations and monitor the health related boards for their discipline to stay informed of the current rules. So just some thoughts on if as a clinician, if you're considering telehealth services for someone, it needs to be determined, the need needs to be determined on a case-by-case basis based on clinical judgment, the person's informed choice, and then professional standards of care. So to determine whether therapy by means of telehealth is in the person's best interest, the therapist must consider the following: the complexity of the person's condition, the knowledge, skills, and competency of the therapy practitioner, the nature and complexity of the intervention, the requirements of the practice setting, and then the person's environment. So just some key points to take away. It's important for each clinician to stay active with their professional association and to monitor the health related boards for their discipline to make sure they're aware of any new rules or laws. And again, starting May 11th, the 16th month interactive telehealth visit rule will go into effect, and the supervision of assistants will have to be in person. David, I think I'm going to pass it over to you.
Well, we are just about out of time, and I wanted to leave some time to see if maybe some of the questions can be answered. The PowerPoint that was up earlier has a few more slides on it that talks about some of the changes that occurred that Medicare made related to telehealth that were permanently made, some of the flexibilities that will actually be extended through 2024, and then a couple of the items that will actually end on May 11th at the end of the public health emergency. And it talks about TennCare guidelines related to telehealth and what is telehealth visit and what is not. So that is going to be posted on our website with this today's CCN. So if y'all want to view the rest of that, please do. Babs, do we have any questions that we need to try to cover real quick?
Yeah, that's great, David. I'm glad you mentioned that about the stuff on the website. I have to jump out of here, but Babs is going to facilitate the questions with you and then close everything up. So I appreciate it. I will catch up with you next time, everybody.
Okay, there's a lot. If we can't get to all of them, we can copy them and upload a question and answer document at the end that I can put up on the website. All right, so Dr. Davis asked a few, but I'll skip his and move into Candy Turner. Would there also need to be consideration for each discipline's licensure requirements, such as telehealth, along with what TennCare adopts? Who wants to take that?
I'll take that. I think with the passing of the telehealth law in April 2022, or yes, 2022, each licensure board will have to adapt or adopt and implement rules to for telehealth. So that is going to be forthcoming. So I can't stress the importance of monitoring your licensure board and your professional association. And if we hear anything, we will definitely pass that on to our community providers.
Okay, next question is from Rita. My understanding is that following the public health emergency ending in May, reimbursement for telehealth services will be reduced for many insurance companies, including Medicare. Some hospitals are already starting to plan to reduce telehealth visits as a result to save money. How will this impact DIDD, people with disabilities in rural areas, for instance, who have been able to get access to more services via telehealth than they might have before the pandemic due to lack of providers in the area?
Well, I can kind of hit on that a little bit. Obviously there's a clear need for telehealth services, and there are going to be provisions to continue telehealth services, but I don't know at what level and what reimbursement. Some of the Medicare extensions are listed in the PowerPoint that extend through 2024, and I think that will allow the majority of services that are currently being provided to continue at least through that, and hopefully by then there'll be other rules in place that will allow it to continue.
Okay, next question. Should a practitioner rely solely on telehealth? What are examples of activities that must be carried out in person?
Well, for nursing, we as in DIDD, we don't do telehealth for nursing because nursing services are direct face-to-face care. So I'd have to defer to Dr. Schuler or Sarah on this question.
Well, I can tell you in psychiatry, one of the things you can't do on telehealth is commit someone to a hospital. You have to see someone in person to do that. And I mean, then there's all the other obvious parts of medicine, you know. I mean, you can't do radiology, you can't do surgery. You can listen to heartbeats and things like that through specialized equipment, but a lot of doctors think that's not very useful. So, I mean, there's still a big part of medicine that needs to be done in person. The majority of psychiatry, as I said, can be done outside of it. I think I just saw Chi say something about a tardive dyskinesia evaluation. You can do a TD evaluation. It's a movement problem from antipsychotics on telehealth. It's just not going to be really good. So those are the sort of things that cameras don't carry out well, but you can do it if you feel comfortable with it.
And I think too, David, that it all depends on the person's needs. We just need to remember that the telehealth session is not for the clinician's convenience, that we have to make decisions on what the person needs.
All right, I'm going to tackle one more. 10 Start is conducting a study on the effectiveness of telehealth in the provision of their services. Can someone talk about that study and hypothesize the findings?
I can chime in for this one. I saw it in the chat. I was like, I guess I better come on for this. So it's not a 10 Start study, so I want to clarify that. It is actually the National Center for Start Services under a PCORI research grant is actually studying the effectiveness of the 10 components of the 10 Start model being applied via telehealth. That had to happen during the pandemic for obvious reasons. But they're now going in to look at different aspects of that model and comparing in a blind comparison group where one group will get part of the services via telehealth and the other will get traditional services. So Tennessee is one of the states that's participating in that telehealth study under the National Center for Start Services. They're anticipating, as far as the hypothesis goes, that some components of the service can be done via telehealth effectively, but there are certain components like crisis response, as well as our intake and assessment process that will all still be done in person, even in the telehealth side of the study. So that will be a multi-year study that we're participating in, but it is not being directed by us. It is very much under PCORI, the National Research Consortium, and the University of New Hampshire through the National Center for Start Services.
Thanks. Okay, one more came in. I want to go ahead and tackle it, and then we'll be done for today. What are the guidance protocol for TennCare members to receive services from Station MD?
Hi, this is David. There is waiver funding available for individuals that want to get Station MD services. If you'd like that information, I'll be glad to email it to you. You can email me at david.taylor@tn.gov.
Awesome. Well, with that, that is our panel for today. I will get this uploaded onto our website. Thank you guys all for being here and participating, and we'll see you next week for the NAD collaboration.
Thanks so much.
Bye, guys.